मेरा आज का show is going to be like a dream come true. So we met an angel who actually did impossible for women in Pakistan, and that is Dr. Shivana Mufti.
What she really understood was that we were suffering because of a lack of source.
Now everybody in Pakistan is talking about menopause, perimenopause, hormones, and BHRT. Dr. Janet Sundberg, Dr. Mary Atkinson, Atkinson, Dr. George Skandar. So this is not an interview, it's an interactive discussion. I mean, such great minds, I only have to listen.
Often in conversation, we hear that menopause is natural.
Yes.
And it's a natural process. And so we must just go through it.
So instead of putting them on antidepressants, and going to the psychiatrist, you need to fix your hormones.
This is what modern medicine is for. It's about optimizing the life that we do have.
We were meant to age on like our grandmothers did.
Yes, that's not just because of me.
You brought them here.
That we are seeing a lot more of inflammation with the estrogen predominant woman.
I think only 4% or 6% of women in US, they're on BHRT.
Yes.
Is that right?
6%.
On
Yeah.
hormone
6%.
therapy, not just BHRT.
Just the
on
hormone,
therapy.
HRT.
I mean,
Talking about awareness, endometriosis is a other big part of
Yeah.
this, because by the time as a surgeon get to see a patient with endometriosis, they have already seen 2-3 conventional doctors.
I'm so happy after taking BHRT. Look at me. I'm an example. Assalamu alaikum and welcome to my channel. मेरा आज का show is going to be like a dream come true. If you all remember who are regular watching this channel, that like 2-3 years back, I started this channel with my problem of getting in menopause and not getting solutions for that. So you all know Dr. Sammiya Razzi is my best friend, who's a doctor as well, and a functional doctor, functional medicine doctor. Together, we went to a lot of conventional doctors, and everybody discouraged us about taking HRT, which is synthetic. So because Sammiya can afford and went abroad and she got BHRT, now I had to get it somehow. And you know, when you really, really want something, somehow God helps you. So we met an angel who actually did impossible for women in Pakistan, and that is Dr. Shivana Mufti, who after talking to us, immediately understood what women in our age are going through in Pakistan.
And what our women in our country lacked in terms of resources.
Resources.
What she really understood was that we were suffering because of a lack of source.
Yeah.
Where do we access all of this? Because, Iffat and I were like hungry little wolves asking her, I want access. And she went ahead and did it. So
Yeah,
she's the
she
pioneer.
did it. So she's the pioneer
She is the pioneer.
of bringing this absolute amazing stuff, I will say, in
Essential.
lame man language, BHRT, and the awareness three of us created together. I mean, one credit I give to this 3 people, that now everybody in Pakistan is talking about menopause, perimenopause, hormones, and BHRT. So today, I said it's a very, very special show, and in our panel, in my esteemed panel, I have to introduce my guests. Dr. Janet Sundberg. Dr. Janet began her career in international business before transitioning to medicine. She holds a BA in Economics and International Relations from Brown. I'm impressed. A Master in Fine and Decorative Arts, Christie London, and an MBA in C. Wow. She worked in marketing and media, CNN, McCann, Ericsson, The Art World, Christie New York, and business development. She then discovered her passion for medicine, and decided to make a drastic career change. She's now a GP, MBBS, King's College London, a lot of more qualifications. I mean, her clinical work focuses on women's health, especially menopause management. Yay! She also advises various startup healthcare companies on growth strategy. So, can you imagine? I mean, what a remarkable woman she is.
Absolutely remarkable.
And it doesn't end here. We have another participant. That is Dr. Mary Atkinson. Atkinson. Wow. And that's a tongue twister. Dr. Mary is a recognized authority on menopause and midlife women's health, with an international patient base and recognition among colleagues in USA, UK, and Australia, and now in Pakistan. With a fellowship in functional medicine from George Washington University, she combines advanced hormone therapy with functional medicine to deliver holistic, evidence-based care. Passionate about breaking the stigma around hormones, she empowers women to replace fear with confidence and confusion with clarity. Someone we needed so bad. Helping them thrive through menopause and beyond. Her own health journey, together with her roles as a wife and a mother of two, deeply informs her work, making her not just a doctor, but a mentor and advocate for women seeking balance, vitality, and strength. Wow. I mean, you can imagine how lucky I am sitting among such great minds. Last but not the least, we thought that there should be a gentleman also part of this panel. I mean, we believe in equality, but the way we have been treated, we thought that 5 women should be like only 1 man is required. Yeah, so we settled with 1. So this is Dr. George Skandar. Dr. Skandar graduated from University of Kansas School of Medicine and completed a residency at University of Tennessee Medical Center. Dr. George Skandar, MD, is another tongue twister obstetrician, gynecologist, and Centerville, VA. Dr. Skandar currently practices with Stone Spring Hospital Center, am I right? Dr. Skandar has experience treating conditions like ovarian cyst, among other conditions, at varying frequency. And that is another thing we really need to know about in this part of the world, where it gets unnoticed. And eventually, when you go to the doctor, it only results in hysterectomy. So this is not an interview, it's an interactive discussion. I mean, such great minds, I only have to listen. So Dr. Sammiya, Dr. Shivana, take over, and I'm just going to listen to all these wonderful people.
Oh, thank you so much for inviting us here. Really, I really appreciate it.
Thank you so much for considering me to do this. Thank you so much.
Like-minded, educated, and very eloquent. And I'm really very grateful for bringing this panel here. There is only 1 testosterone there, like,
yeah,
imagine,
that's how we've been treated all our lives. With 5 men, only 1 woman representing women.
But with that 1 testosterone, with the percentage of the estrogen here, but the estrogen and the BHRT is not very prevalent as compared to that. The testosterone is so much available in Pakistan for men. So
because the studies have been around only men, because they were getting heart attacks more. Yeah. And so every research, every study was based for men. And 1/3 of your life, of women's life after longevity, you
at least.
I mean, common sense tells that after menopause, if you are not getting something in your body, you've been done with that. Common sense tells, like calcium, if you're lacking it, you take supplements. If you don't creating hormones anymore, you should be taking them.
So let's start with more with basics, and because your viewers need to know what the menopause is.
Yeah.
And if we're talking about bioidentical, which is BHRT versus HRT versus synthetic, what's the difference and why we're sitting here to create awareness among the women of Pakistan. So who wants to answer what the menopause is?
Can I maybe come in there, Shivana? And I think it is such an important question, because often in conversation we hear that menopause is natural. And it's a natural process, and so we must just go through it. And then there seems to be such a debate around should you treat it, shouldn't you treat it? And the point is that 80% of women have symptoms, and often debilitating symptoms, which should be treated, right? Across the world, it doesn't matter which guideline we look at, the number one recognized treatment for menopausal symptoms is hormone replacement therapy, right? So I think that's the first thing is, and also to understand that the whole concept of the natural process is whether we then choose hormone therapy or not, or choose to treat it or not, it's really important to understand that when we go through menopause, biologically, we age faster. So we age faster in terms of our bones, our skin, our brain, our heart. And so that's the point at which we must start, is to say, so what am I going to do about that? I need to intentionally think about my health going forward. And if I then choose to only use movement or exercise or diet or multivitamins or whatever, that can get me this far. But we've got to intentionally go, okay, this is a time in my life where I'll age more quickly. What am I going to do about that? And beyond a shadow of a doubt, there is no doubt that hormone therapy is a cornerstone in helping that aging process.
Yes,
right?
absolutely.
And helping you do better. Apart from the fact that for those 80% of women who have debilitating symptoms, it is the most effective treatment.
You know, in our country, in Pakistan, when I was doing all this research, out of 4, 1 after menopause, after 40s, they're on antidepressant.
Exactly.
They think when they're having mood swings, they're going through some crazy episode of depression and they can't sleep, there is insomnia. And then they get up in the middle of night and they go to bathroom to pee all the time. And of course, when you're not sleeping well, you're going to be super fatigued in the morning and you can't function well. So instead of putting them on antidepressants, and going to the psychiatrist, you need to fix your hormones.
Your root cause.
Yeah, your root cause. And that brings me to the fact you have a story to tell about that.
Well, just in what you started about, what Mary started saying, Dr. Atkinson started saying about that, what can we do about it? And it's one thing, we give insulin to diabetic patients and don't think twice about it for life. We give levothyroxine to patients with hypothyroidism without thinking twice. We treat high blood pressure with antihypertensives for life. Nobody questions. That's a modern phenomenon, right? What else? Statins or treating hyperlipidemias of various types. We remove appendices that are about to burst that could kill you. We cut out cancers. We take out uteruses for the right reasons sometimes. And all these interventions, this is what modern medicine is for. It's about optimizing the life that we do have. Sort of one of my favorite phrases is always adding years to life, not life to years.
Yeah.
No, other way around. Adding life to years, and it's
Quality,
about health span, not lifespan first. Women live longer than men, I think it's between about 4.5 to 6 years longer, the average woman from the average man. That's all well and good, but we spend 24% of our lives, women, in ill health than men do.
Yes.
And it's not because we live longer. It's a factor, but it's certainly not.
No.
So all these things we treat, and somehow, yes, it's natural. It's not a disease. It happens to all of us.
All
In fact,
of us.
it's none of this it's a bit of a niche, this menopause treatment thing. You know, we get that a
And
lot.
there's so much discouragement with conventional
Yes.
doctors about it. I don't understand.
There's a good reason for it, though.
Not
and
just
it's a
the
little,
doctors, I think patients as well.
As a consequence.
Yes.
Absolutely.
They come up with these questions like, we were meant to age out like our grandmothers did.
Yes.
We also
Do you not
weren't
get
meant
that a lot?
And
to
my
live till we
grandmother,
were 70, 80. We
Yes.
all, our life
Exactly.
life expectancy 100 years ago was
Exactly, it was 35.
50, 35 to 50-ish,
Yeah,
right?
yeah.
So there was no
This
limit.
life.
Yeah, exactly.
yeah,
So
yeah.
with this, I mean, we treat, walkers, walking canes, like
Is that
wheelchairs.
natural?
Like, is that natural? Yeah, exactly.
Yeah,
And, but the one thing it seems like modern medicine thinks we should treat naturally
Oh, yeah.
and watch women suffer, and not just, oh, it's an inconvenience, really suffer, is menopause for some reason. For some reason, that double standard is so ingrained globally.
Yes.
Yeah,
globally,
I mean,
like,
just
so
imagine
intrinsic.
these women, if they had gone through this, Sammiya, then this woman is a magician.
no,
Because
honestly,
in this
you know,
part of the world, creating this awareness and doing so much, Shivana, I mean, hats off.
thank you
to
so much. But that's not just because of me.
You've brought them here.
No,
I
but
find this
that's not just
incredible.
because of me. I remember 2 years ago, I was talking to you on the podcast, and I was like, I need some help local because there is so much resistance, the barrier of communication, and the doctors are resistant to it. And I think it's somehow they think when we bring the knowledge, when we're bringing back to the community from the Western world, it's like they have some kind of, I don't know what kind of resistance that you know more than us. We are surgeons, and there shouldn't be any insecurity or there shouldn't be any shame. Myself, I went back to school to get specialization 5 years ago. I was a traditional gynecologist, and honestly, after learning all this functional medicine, going and learning to conferences, updating myself, I thought, what kind of doctor I am? I'm not making a difference in women's life.
Yeah.
And not only that, there is no impact, there is no quality of life. I do annual exams, PAPs, and then do hysterectomies, deliver the babies. But what about the women in 40s or sometimes late 30s? And now with the PCOS, which is the hormonal imbalance, so much going on in their life. And the doctors just tell them, oh, this is natural. And women feel being dismissed.
Yes.
At least listen to them. Or this is what's happening, and not just in Pakistan. It's a global thing. Don't you agree?
I think one of the things that when I look at most women who really are campaigning in terms of menopause, it's usually because we've been through it.
Yes.
And everybody's personal journey,
Until
let
you go
all of
through
us
it.
to this path.
I turned 40, and the first thing, and I'm an athlete. I mounted,
Yeah,
I
you
did the
told me.
Kilimanjaro, the Inca trails, and I'm with all my independent spirit. I think I was 40, 41. I developed this frozen shoulder. Can you believe
The
it?
first thing that happened.
That
happened to me.
Tying
I
your bra becomes a task.
Actually, tying it is okay, but the undoing,
Oh God!
technically speaking, just takes one to know one.
It's like the frozen shoulder.
George, surely you need to weigh in on this part.
You know, when we were talking about PCOS and even endometriosis, I mean, these are problems women go through without, any diagnosis, help. So how much hormones play part in this, and what's that all about?
So, of course, hormones plays a major part. We are seeing a global obesity pandemic everywhere. All this excessive estrogen turns into our body into kind of like, I like to say this is, one is like the gas, one is like the brakes. We have so much gas but no brakes. And because of that, we are seeing a lot more of inflammation with the estrogen predominant woman. So the other thing too is, like, we're sitting here talking about awareness. Endometriosis is a other big part of this, because by the time as a surgeon get to see a patient with endometriosis, they have already seen 2-3 conventional doctors. Their pain has been ignored. Average time to see a surgeon is usually 2 to 3 years behind from the onset of symptoms until they are refer to see a surgeon. So that's another issue or topic.
Even abroad.
Yes, absolutely.
That's in the US, is it?
Yes.
So you're not that far. I brought it here.
Yeah. I mean, thanks to you.
The hormone replacement therapy, I don't know, correct me if I'm wrong, I think only 4% or 6% of women in US, they're on BHRT.
Yes.
Is that right?
5%.
On hormone therapy, not just BHRT.
Just the
on
hormone,
therapy.
I
HRT.
mean, now it's been talked about Oprah.
You are the Oprah of today.
I mean, in Pakistan, being in showbiz, I mean, nobody talks about their age. So I openly
That's
did.
the other thing.
Yeah.
Yeah, I was going to ask, like, what's the cultural
People
layer
hide
here?
even
Additional.
because they feel
always
like
that.
being
young to be
rejected
60,
if they
that's
tell
for
openly I'm menopause. It's taken like this. Your life is finished.
It's an insult.
You are no more attractive. You're not supposed to do certain things. You can't wear red lipstick. What are you doing? Looking good after
The
certain age
anti-stigma.
is unacceptable
The
here.
anti-stigma.
I don't know how
Just
to draw.
supposed to disappear.
Yeah, you're just supposed to.
Only
disappear.
grandmother roles.
Not only
Exactly.
that, my personal experience.
But I can play grandmother role, but I can look like this. But I will be a grandmother
Well,
in
this
a
is
couple
what
of
a
years.
grandmother looks like.
Yeah,
now,
exactly.
Right?
I'm
Absolutely
53
can be.
and I'm so happy after taking BHRT. Look at me. I'm an example.
But when I was doing this, like I think it's last year when I prescribed some testosterone to some women, and you know what? And I was talking about it in another TV show, and the feedback which I got, you're just increasing the sexual desire of a woman without understanding that testosterone has so many other
Well, I'm glad they
roles.
knew about this.
That at least.
At least.
At the end
But
of the start.
otherwise, they would have. Why are you giving us male hormones?
But let's say, if that's the only purpose, let's just keep it like that.
So is it bad?
Is it bad?
No.
I know,
So
I
the
was
women
gonna
are not
say-
supposed to have like a
Yes,
normal
exactly.
sexual desire or
Exactly.
normal life
Exactly.
or being with your partner or husband after a certain age. So why do we forget the hormones are all about keeping the health span, the lifespan, and the sexual and emotional span all parallel? Why do you have to cut short one span and then just saying we need to increase the quality of life, and that encompasses all the spans together?
Exactly.
And he does a lot of testosterone.
Well, can I add to that? So one interesting factors for this awareness, basically, it's that there's estrogen and testosterone receptor in every single cell. So when you're saying sexual desire, well, you have testosterone and estrogen receptor in your hair, in your eyes, actually in your teeth too, in your bones. It's in every single organ. So it's actually an understatement to think it's all about
why would it
sexual.
be?
Yes.
Yes.
But only about sexual, but it's a full on body health and wellness programs.
And also in women in particular, men too, to an extent, libido or sexual desire is
Is a
it's
mood.
not a exactly. That's it's a mood.
It's a brain symptom.
Yeah.
It's a brain thing. More so for women than for men, to some extent both.
I mean,
but
of
very, very
course.
much, right? Exactly. So obvious to us, right? And some people say like your setup or the foreplay or the leading up to the next sexual encounter with your partner starts at the end of the previous one.
Oh, yeah.
Yeah.
And it's not about that evening or that day, it's about the lead up to, and all that affects your mood, your outlook on life, how you think, how you feel about your partner, about yourself.
Yeah.
About yourself even. Sometimes it has nothing to do with your partner.
Yeah.
The libido thing, right? It's how
Exactly.
you feel in and of
That's
yourself.
why general
And-
stressors contribute so much to your libido.
Yeah.
People who go through stress at work, they're
Absolutely.
not going to come home and want
And
to really
Stress
have.
at work.
At home,
Tell us
stress at home with
Jenny,
4
tell us
kids.
the stats. How many women in 40s start having those feelings that I want to quit my work? You were telling me this morning.
So the question was, how does not taking? So actually, before I do that, an interesting perspective now in the US and the UK with BHRT or with menopause management is it was always, but what are the risks? The risk versus the risk, and the fear of the risks. Now it's shifting a little bit to what are the risks of not taking?
Exactly.
What are the risks of not just keeping on what has been hugely protective, which has naturally been occurring in us our lives, which is why we are much better off than the men earlier days from things like cardiovascular disease in particular, but also other things that happen more to women than men, like our bone, like our osteoporosis and so on. And then we fall off a cliff with two of the three hormones, right? The estrogen and the progesterone. The testosterone, to your point, George, about how, you know, testosterone is in every single cell of our tissue. When we were, I speak for the whole group here, in our 20s and late 20s and late 20s, early 30s, our level of testosterone was 3 to 4 times higher than our level of estrogen, of circulating, if you compare it on a molar concentration level.
Exactly.
And everybody's like, I'm sorry, what? But testosterone, that's a male hormone, even amongst doctors still. Oh, estrogen, that's a female hormone.
Exactly.
You know? George, when he becomes a 60-year-old man, will have more estrogen in his body than we will.
So
exactly, naturally, right? So the question was also, so how does this, in terms of risks of not taking, there's all the medical risks and the psychological and so on. You know, there's that's a topic in and of itself. But what one of my most shocking, and I didn't believe it until I really heard it, and 10 to 20% of women leave their jobs in this time because they cannot manage with the symptoms. Their confidence goes, their ability to function, their trust in themselves, the word search, the brain fog, the
memory lapse.
Well, exactly. All this
fog.
stuff, and it's a little bit like getting the rug pulled out from under you when you've always been super together.
And then you're judged as well. I mean, people around you start judging you as well. You need to go home. Why are you so cranky?
Yeah, mood is another thing too, right?
Yeah.
Mood and memory, and when the sleep doesn't function, then if for any human being at any age, you know, when you're not sleeping, the rest of it, you know, the fallout of that is just a downward spiral on every level. So relationships as well, it's the highest time of divorces.
Yes.
Age 45 to 55, the average age of menopause, because and it's not purely because of the menopause, but as one of the major contributing factor, it is big. You know, plays a big role. There are often aging parents. There are children at varying ages, teenagers maybe, who are going through their own. You know? Absolutely. Yeah. They're huge turmoil with their adolescence and hormones and this whole thing, you know, and it's a real time of transition, not to mention the hormone transition, and it leaves a lot of relationships
I've seen, you know, I'm so sorry to cut you, but coming back to that point about the incidence of divorce increasing, there are certain people who come to me for Pilates, and what I've seen, especially in my movement practices, that a lot of women now are getting married later and later in life because they've been pursuing some careers. Yeah. So I had this one student. She had gotten married at the age of 45 for the first time in her life. And she discussed things with me because she wanted to end that marriage within the first 6 months. And she just asked me for some advice. So I asked her a few questions, like, does he regulate you, blah, blah, blah. Does he hit you? Is the sexual life good, etc., etc. When everything fell into place, I said, you had your hormones checked. Maybe this is not the right age to get married for the first time in your life.
With so much,
You know, the anger issues. Yes. And that's what most of the women complain, that they lose their anger for no reason. And their anger is disproportionate. Their response to certain thing is disproportionate. And then they feel angry even at their kids. And then most of the women, they say, oh, maybe we have become mature, we have become wiser, so we're not going to take any BS, I'm sorry, like, excuse my language, from anybody. And then maybe we have no tolerance because these are negative people, or these are like, you know, they're bringing negativity to my life, or my in-laws gave me so much stress, or my life gave me so much stress, or my ex-husband gave me so much stress. That's who I am right now. Those factors are some part or the fraction of the equation. But the rest of the things, when you're in your 40s, then these hormonal fluctuations amplify everything what you were going through. So just saying that because of the life stresses, that's not enough. You have to find the underlying issue, that why you are losing the tolerance. If you have gotten mature, then you should be more calmer.
Yeah.
You should be more responsive, use your emotional intelligence. So obviously you're getting older, mature, and wiser, but when you're not able to respond to the situation according to the proportion, and then you feel guilty afterwards when you yell or scream at someone, and then it means that there is something underlying which is going in your body, and you just can't control.
Mental rage,
Awareness,
you know,
I
there's
mean,
a word
sorry,
for it.
I'm also cutting it. But awareness needs to be for men
the
as well,
spouses.
to understand what
much,
your
yeah.
female partner is
going
going
through.
Yeah.
I mean, I don't know about abroad, but here women are considered useless after a certain age.
Yeah.
All right.
And they believe it themselves.
And then it is so indoctrined that women themselves, you know, act like
Well, you
they
feed
just-
into it, of
Yeah.
course, right? You
I
buy
think
it.
George has been struggling to say something.
Yeah.
I would like to add
I know, it's hard to get a
something.
word in edgewise, I apologize.
We give him a chance.
I would like to add, so like building on what you guys saying, so the concept of hormone replacement versus hormone optimization is another good concept.
That
So
is
Yeah.
very
in a simple way, like we all now have Apple Watches, we have iPhone. You can't wait that if your battery is running down to 1% or 2%, you're not able to watch YouTube and chat and use the phone and everything. Well, if you optimize your battery health to 80 to 100%, now you're able to use more. So when I even counsel patient about hormone replacement in the office, most of the time traditional medicine wait till your hormones, like you said, fail out of cliff
Yeah, exactly.
to start to replacing it. And when they replace it, they want the lowest
Baseline,
possible dose, which is
That's
basically getting you just powering on your phone.
Yes.
Versus now what you guys
You
saying.
still have no
is
functionality.
Yeah, exactly. Just teasing you a little bit,
versus
right?
like
Comes back
needing
up.
to deal with all this life stressor, kids, husband, work, job, and everything. It's a multitask thing that you need a full optimization rather than just not even replacing.
That was the guideline,
Yes.
remember? It
Yes.
was the lowest possible dose for the
shortest
minimum
time.
time.
Which has no scientific basis at all.
Whatsoever.
So I think
We've completely
that
debunked,
statement,
right?
which has just been accepted as the norm, is completely based in fear, and there is zero scientific basis to understanding that.
And
I
also,
just-
there's an underlying psychological implication with that
Absolutely.
phrase. Not just
Absolutely.
is it accurate technically or not, but there's a implication that it is harmful and that it's minimum, as little as possible for just because it's not a good thing. So it's what can we get away with before we really start doing the harm? And the harm is, of course, the risk of breast cancer.
Yeah,
say,
I mean, the cancer word itself
Yes.
is like makes you.
Yeah.
I mean, I was told because in my family, I have history of cancer. But then again, when I saw pros and cons, I made a decision myself that even smoking can cause me cancer, and I do smoke, right? And then maybe genetically I will get cancer eventually. Even 2 glasses of wine in a week is 40 times more risky than having BHRT for cancer. So when you see pros and cons, I would want quality life, not just
Yeah,
life.
not just life.
But I
Yeah.
think it is important in terms of the cancer risk to know that hormone replacement therapy in the form of, if we separate them out, right? If we look at estrogen, estrogen hormone replacement has never been shown to cause, there's a difference as well between cause and risk, right? So
All right.
number one, has never been shown to cause cancer. Neither has it been shown to increase the risk of cancer. So that's estrogen. In
That's
fact,
so
in the
important,
studies,
that
in fact, in the studies, and most of the research that came was obviously from the Women's Health Initiative and which was a randomized controlled study. In that study, when women were on combined equine estrogen alone, their risk of breast cancer actually went down, right? So there was actually a preventive aspect to it. The question comes around the synthetic progestin. And there is a big difference between a synthetic progestin even the many that there are in that class and the different effect that they have, and body identical natural progesterone, right? Body identical natural progesterone is like the progesterone that we make and have in our body. And there is definitely a difference in terms of the potential for the increase in the risk of breast cancer, not again cause, potential for risk, between a synthetic estrogen, a synthetic progesterone, a synthetic progestin as we call it, and natural body identical progesterone, which now in follow-up studies at 9 years, there is no increased risk, right?
So it brings me to the point, as you all know, my full-time practice is in USA, but I see patients online and in Pakistan. My clinic is in Gulberg. So when I see these patients who are coming from other doctors, they usually tell me, going back to the same point, optimization versus symptomatic, they give them like a very small dose and tell them, don't use them for 3 months. That's a normal routine here. And they think like giving them a small dose for 3 months is a normal routine. Because they have synthetic hormones, they don't even have transdermal or bioidentical. So all women and doctors combined, they're very afraid of the potential risk of breast cancer. So when I launched BHRT and I teach and train doctors here, the first thing we have to tell them, and that's what I do in the awareness sessions, estrogen doesn't cause cancer. Because if it was supposed to be causing cancer, then a 20-year-old, when she has the max estrogen in her body, estradiol, they all should have cancers.
And
So
women who have had a lot of children.
yes,
Which
they
is
should
not,
have
That's
cancers.
your highest estrogen level. There should be a corresponding number
So
of...
it's the synthetic progestin part which is the reason, and that's what all the studies are showing. So the
Exactly.
transdermal route is very, very important through the skin. That's what we say, the topical, which is again going straight to your blood, and it keeps the same molecular structure which is present in a younger girl when you're 20 and 30. So the same thing you're introducing, so it's not different. So we shouldn't be afraid of the cancer risk when you're doing BHRT or HRT, which is the
And
synonym
that too
of each
under
other.
like a doctor's instruction,
Supervision.
lot of
And
so
so even the-
testing, and
Yeah.
I know it's expensive, but the more the need
It's
will
not gonna be-
increase,
It's
more
gonna be
patients
costly.
will come,
But-
then it will get feasible for a lot of people.
Yes.
Only we need to create the demand.
Demand.
And everybody needs to understand that it's not about at what age you die, it's about what condition you die.
Yeah,
So
how you live.
as long as I live, I want to be on my feet, I want to be feeling good, I want to be confident. I mean, that is my motto.
For the breast cancer part, even if you have a history of family history, it's very important. The breast cancer family history, or even if you're BRCA positive, the genes you are carrying, you're still the candidate. So you should not worry about the, of course you get the ultrasounds or the mammograms and you're doing it under doctor's supervision. Just because of the fear factor of the future risk of breast cancer, you're going to develop without it more, because you are going to develop the inflammation which is the menopause by definition is metaflammaging. It's a metabolic disorders, it's inflammation and the aging. So DNA damage, whatever is happening in your body, and the kind of estrogen which is produced in menopausal women is different than estradiol. So the inflammation is happening. You need to bring the balance back. So if you bring the balance back, you subside the inflammation, the risk of breast cancer actually would go down.
Decreases, yeah. That's the latest
Exactly,
studies have shown.
absolutely,
After BHRT, your risk of getting cancer or heart problems goes low.
And I think that's the really important point there, is that there's a lot of women, and certainly in my practice, the first thing that anybody ever says to me is, but what about breast cancer? And that's because there is such a fear about it. But what women don't understand is that the leading cause of death is heart disease.
Yeah.
Exactly.
And actually, we have very good evidence that hormone replacement therapy, and especially in this case, obviously BHRT, reduces the incidence of heart disease, right? And on many different levels. And we know that women's risk of heart disease exceeds that of men post-menopause, And yet we always worry about men and their hearts, you know, as they get older. But actually, women's risk of heart disease is higher than men.
And nobody talks about
Nobody
it.
talks about that. And it's much higher. It's 8
women
times
don't get
higher
their
than
blood
breast
pressure
cancer.
checked.
Yeah.
exactly. It's what 1 in 7 women will get breast cancer in their lifetime.
Yes.
And 1 in 3 women,
So it is
even higher, will
it is
die from
much
heart
higher.
disease.
It is much higher.
And
It's
so
the
cu-
leading
and
cause
yet-
of death.
Yeah,
And then second
yeah.
to that is that 1 in 2 women over the age of 50 will fracture.
Yes.
Yes.
And the only registered therapy for the prevention of osteoporosis is estrogen.
Yes.
So, you know, these are 2 massive debilitating conditions that far outweigh in numbers
Yeah.
breast cancer. And yet breast cancer is what stops us when hormone therapy doesn't cause breast cancer. You know, so we make these decisions. Back to your point around, we sort of feel like we come to menopause and there's so much concern that, okay, I just won't do it. But we don't think about, what if I don't do it?
Yeah.
You know, what is the actual data showing in terms of how women age and what the true issues are in terms of from a health perspective? And how can the decision that I make today, for or against whatever path I'm choosing, contribute to making my life better or potentially worse? And for sure, that's why, even again, back to the good old traditional guidelines, is that across the world, in terms of hormone therapy, the benefits outweigh the risks. And when we truly evaluate the risks are usually associated with traditional hormone therapy and
absolutely.
not with body identical HRT.
Oral, yeah.
Because it's related to clots and it's related to, you know, all of that. So for sure, we've got to be educating women that we've got to stop thinking about the things that it actually doesn't do and think about what it does do in terms of reducing risk of heart disease and reducing risk of osteoporosis and
Reducing colorectal cancer.
reducing colorectal cancer, reducing the risk of diabetes.
Diabetes.
Yeah,
Hypertension. Hyperlipidemia.
Yeah.
exactly.
I mean, all the anti-inflammatory
Yes.
diseases that women suffer from twice as much as men. So 2/3 of chronic disease, 2/3 of autoimmune disease, 2/3 of all dementia patients
Oh, God.
are
Yes.
women. That's another big
Women
one,
have
right?
Big one.
twice as much. So 1 in, you know, as men, right?
You know how many hysterectomies are done in this country? So common procedure. And the recent study has shown that if you do hysterectomy, removal of uterus, it increases the risk of stroke by 9%. And if you take the ovaries out and keep the uterus in, the risk of stroke increases by 13%. And if you take both out, then you're increasing the stroke by 55%.
Can you imagine?
So you're doing all this, you're removing, or on the other side also, as we were discussing this morning, you give birth control pills, which is synthetic hormone, like water pills.
Yeah.
For decades.
And the dose it's a much higher
Much
dose.
higher.
Yes.
Yeah, that's
So-
another
I mean,
super
that
important
is
point.
being given for your skin problems,
Yes.
for
God,
everything
yeah.
Yes,
a woman goes
just
through.
regulating
they
periods.
put you on this birth control pills.
Yes.
But the
absolutely.
irony that it can cause the symptoms that you're actually trying to fix. So some of the side effects of, so the right oral or whatever birth control pill for some women, which will help with libido, mood, skin, and obviously contraceptive reasons, right? And regulate periods and make them less, you know, on any number of things. Lots of women will get mood swings and not good ones, suicidal thoughts, depression, anxiety, will get worse skin from it. Will get, so it's a bit of a carousel of trying and seeing what works on the contraception front, but they're all synthetic
Yet
and
nobody
in
has an
super high
issue
doses.
with the contraception.
you were
versus-
just
No,
telling
exactly.
me-
No issues. It's starting now, though, isn't it? We're starting to
You know,
question,
one
like, I
way
don't
of
give a young women.
selling, we're not selling, but we're advocating, like the
The idea. Telling the idea.
Edit.
but selling because they're selling the cosmetics,
Yeah.
right?
Yeah.
So that's where the terminology where I'm using is instilling that idea of the hormone replacement therapy, if we tell the patients it's going to make your skin beautiful.
Oh, they'll buy
Yeah.
it.
They'll buy it like crazy.
Yeah.
Like, you know,
Yeah.
they'll buy it crazy.
yeah.
So it's like, okay, forget about the health benefits. Forget about the health benefits.
your hair
Your
grow.
hair will get better. Your skin will get better. Your, like, you know, all those things. You're going to get...
Oh,
your,
they don't
your
care.
vision will get
Yeah.
better.
They don't care.
They don't
Your
care about
taste.
that.
You're like the
I mean,
ring
somebody like
sensation.
me will be sold with skin and hair.
That's
Yeah.
what I'm saying.
Started
But that's
getting,
not the...
erosion of my mucosa because it can be edited completely, but this was such an interesting story. And I go to a really good dentist here, and he would fix that. But then I went to somebody in Austin, USA, and he said, "Have you been off your BHRT?" And I said, "Yes, lately."
The dentist said this.
Yes.
Oh my God.
Yes.
Oh my God. Hang on to him.
This was this guy in Austin who was very expensive and very renowned. And he said, "You know that you have estrogen receptors in your mouth.
Yeah.
And maybe it's not that your bone is protruding out, it's your mucosa that's getting weak."
That is receding in your
And oh my God, it was
It
miraculous.
makes sense. I mean,
Yeah, the ringing
Well, if it's
sensation
everywhere,
in the
why-
ears.
Yes.
And
The
like,
tinnitus,
you go to ENT, and then they're seeing all these things, and oh, there's nothing wrong. It's similar, like a frozen shoulder. They do all the expensive X-rays, they do the physical therapy, and they do the MRIs, and they tell you, oh, it's just the inflammation, and just don't do anything.
But no root cause.
normal
Yeah.
aging,
It's a normal
exactly.
aging.
When this happens, you know you're aging.
Mary,
I think that
Yeah.
is
Maybe
one of the-
everybody needs to study functional medicine. now.
Yes, exactly, right? So I think that is the one thing is that menopause is always seen as this point in time where all of a sudden you go from lots of hormones to no hormones, and then you get some hot flashes and your period stops. Like that's menopause. Done. Okay, let's move on. And actually, menopause, we have to start seeing it as the journey that it is and recognizing that perimenopause is probably the time when metabolically the body is changing the most. And that hormonal change is affecting the brain the most. So we speak about the increased risk of dementia, right? So the changes that are going on in the brain during perimenopause, at which stage your period is still there, still
Yes,
regular,
yes.
everything's still fine. And that's why the mood symptoms come up so much during that time. And so you've got your woman in her 40s, and she's usually got young kids, and she's kind of in a workplace. So she's kind of, got that sort of career level going, and everyone's going, "You're just stressed. It's okay, just take a holiday, just take a break." And it's so easy to...
Have a glass of wine.
Exactly.
You should meditate.
Yeah, yes,
Oh,
exactly.
that's my favorite. That's my
Yeah.
favorite. And black cohosh and shatavari and ashwagandha and shilajit and like primrose. But that's the supplementation. You should be doing that,
Yes.
just like
Yeah.
exercising. You should be
Exactly.
exercising. Your diet
Exactly.
should be good.
Yes.
But are you gonna take, if you have thyroid issues, are you just gonna take selenium
Exactly.
and Brazilian nuts and you can
Exactly.
fix your thyroid?
Exactly.
Haven't tried it. Maybe.
We have to do studies on that as well. Okay, right now, let's come to this point. Who is not eligible for BHRT? Is there any reason you can't take it ever?
I can. So I will say this is the great thing. So like the estrogen and progesterone is meant for prevention of endometrial cancer. I do like to tell people all the time, we don't compromise the oncological care, because I do GYN cancer a lot, in favor of the hormones. So before you do the hormones, I will tell you two things are very important. You need a thorough history and physical exam to determine the fact that you don't have a contraindication. Now, the contraindication are getting less and less because everything is getting better in medicine. I like to use this word, like if your car is getting improved and better technology, medicine is also improving.
Definitely.
So there are less and less contraindication. However, you shouldn't be placing hormone replacement therapy in a patient that has a real contraindication. And
Okay.
I really mean real contraindication. Like you shouldn't do a hormone replacement therapy on a patient that actively have postmenopausal bleeding. You have to finish the evaluation first determine the patient is safe, and then you can proceed with hormone replacement therapy. If you have a patient that even have fibroids or have endometriosis or have an issue, you have to have a patient-doctor discussion, determine their safety first, and then you can proceed with hormone replacement therapy. It's not contraindication, or it's an absolute contraindication, but it needs awareness.
But after
when do I
menopause,
see
your
it?
endometriosis and bleeding does go away, no?
Most of the time, yes. But if you do have fibroid and you are placing hormones, there is an activation of the fibroids too. So some people, not everybody, will have bleeding on the hormone replacement therapy. And again, they would require evaluation. They do not require discontinuation, but they require evaluation.
All right.
Yes.
Okay.
And you shouldn't be placing it on, like we in the US we do like history, physical exam, and a lot of time we order an ultrasound to confirm it's safe before proceeding with hormone replacement therapy.
But what about if you had cancer? You were a cancer patient, but now you are healed and in remission.
It depends
They
on the
can have
cancer.
it or no?
Yes.
It
yes.
depends on,
Depends on the type of
Skandar
cancer.
was saying, like, there is absolute contraindications where you should not be on it, and then there is relative where you can do it with under the doctor's supervision. So absolute is if you have a personal history of breast cancer, you should not be on hormones. I attended a recent conference where the doctors were taking, and they were breast cancer survivors, but they were out, they were in the remission for the last 10 years or so, and they were taking it under the team of oncologist, endocrinologist, and the gynecologist.
Yeah, I
So
think,
it has to be the teamwork.
I think
it
that's
has
exactly
It has
the-
changed
yeah.
in the recent year.
yeah.
The stigma around having breast cancer has improved significantly. In the US, we work with the breast surgeon. They will refer the patient to us, and it's a shared patient decision making. Like, we discuss with them the benefit, the risk, and then we can proceed. But to your point, the absolute ones is usually if you have a history of stroke or you have a history of DVT or blood clots. And again, those are kind of extremes condition that you shouldn't be taking hormone replacement therapy. Again, with the advances of medicine, you can discuss it with your physician and make a shared physician-patient decision-making rather than it's an absolute contraindication.
And liver damage, like active liver damage.
And what about hysterectomy and your ovaries are removed?
You should be on it, actually.
That's the time to.
That's
the
the
time.
You
know,
know,
when I-
doctors
Surgical-
here say
surgical-
you are not even have an option of taking that. A lot of my
You know,
friends
when-
who have been gone through all this early in their ages, I mean, I now feel so sorry for them because
you know-
what they have become.
It is the equivalent of castration in a man.
Exactly.
At 40 years
And
old,
they were
castration
told.
overnight.
So menopause
Boom, well
before
said.
age 40
But
is
it is.
premature ovarian
Can you imagine?
failure or premature
That
ovarian
was-
insufficiency.
Yes.
Or if you remove surgically, if the doctor is doing some endometriotic cyst removal or something, they remove the ovaries, that's surgical menopause. And it happens because of autoimmune or just for no reason, family history or something. Before 40 is premature ovarian insufficiency. These people are at the most risk of all these chronic illnesses which we were just discussing.
And I have a very close friend of mine who menopaused at age of 38.
Yes.
Yes.
And now she's going through heart problems. She's going through osteoporosis. She is going through, I don't know what you call them, like
Memory loss,
memory
Alzheimer's.
loss,
Brain
and
fog.
Yeah.
seizures.
Seizures.
She's getting seizures.
That is one of the
Basically,
consequences.
Can you believe that?
Yeah.
Yes.
It's like you put the
Sadly.
foot on the accelerator of the car, which the things which were supposed to happen after the hormones are gone, which is the average is 49, 50, 51. Now it started happening more suddenly. Surgical menopause,
Is the word.
because you're removing the the ovaries,
That was
testosterone.
natural. She just menopaused.
Menopause, that's premature.
sure.
So that's a crime. I always say these women, if they're not on hormones, the doctor is doing a crime.
Yeah.
I agree.
I honestly,
I mean, when I look at Fia, I mean, she has never been well after that.
the premature ovarian failure incidence was 1% before, and now it has risen up to
Yes,
4%.
I wanted to
Why?
bring this up.
What do you
Yeah,
think?
why has
Why
it
is
gone
this
up so
happening?
much?
I think it's
Like
our food and
environmental,
our
The food,
processed
the toxins, the
food.
chemicals, the PCOS,
inflammation,
the stress,
inflammation,
all our
stress.
Why
all
must
the
we
nutrients
what do we-
evolving?
yeah,
I mean,
yeah.
you know,
It's
I mean,
usual
it had
and
been
yet
happening.
avoiding
We
social
haven't got
media, this
used to
thing.
this.
Yeah, exactly.
These screens,
I
these chemicals.
know.
You know, your 13-year-old can tell you more about the makeup from the Sephora and the chemicals and toxins they're putting on their face,
Yeah.
and the cosmetic lenses. My daughter knows more about
I don't mind
lashes
that.
and things.
Yeah.
But when I was practicing, and you may say like I'm biased towards that because I'm seeing that population which are having these issues, and they come to me in Pakistan. It's like, please fix my issues, and no doctor is giving it to them, and they just say like do it for 3 months or something. The saddest part is like women who come to me like 34, 35, they're experiencing premature ovarian insufficiency,
Yes.
and some of them they are not married.
Yes.
And the biggest issue is they come to you and they'll tell you, am I supposed to tell because my marriage is in a year or so? Should I tell my in-laws that I cannot have a baby? Or like, okay, there's a social stigma. What should I tell her? Because in this country, getting married, you're getting married when you're thinking of babies. And still, you know, so many women say like, I don't want to have baby, but how much percentage is that? Majority is getting married to make babies. And now finally they got a good rishta and they're good person to get married. And now the ovary stop functioning.
Yes.
So it's a sad
So
part.
tragic,
It has risen, the premature ovarian failure. And it's like, oh, that I can tell you, that's an ethical dilemma. I don't know, you should be telling your to-be husband or not. That's something between you and them.
I think you
can-
should. I mean, if
If I were
It's
the
like-
I have
the
to give an
man-
opinion,
If the man cannot perform, you know, there's so many marriages
they don't tell. They don't tell.
They don't
Yeah.
or they just don't tell, and then they find out after marriage like he had some ED issues. So it's similar to women, like they cannot have baby and then she cannot have baby, but they don't open up.
Yeah.
So why
Well,
should
that's
she?
the point.
Yeah.
But
It's
a
time for
balance-
our revenge then.
Yeah. The point to that, though, is to have the conversation early enough, because certainly in the sort of perimenopausal time, you need to explore what can be done. And this is a premature ovarian insufficiency. So I need to explore what can be done from a fertility perspective and fertility preserving
Yeah,
perspective,
it can't
right?
happen in one day.
the
So
sooner
there must
you
have
talk
been
about it, the
symptoms.
better.
Yeah. There must have been symptoms before. It can't happen suddenly.
But
that
It
your
can
ovaries
though,
stop.
because some women only realize they have PCOS or endometriosis or something when they try to get pregnant.
Yeah,
Or they have
most
been
of the
trying.
people,
If you've
yeah.
got major symptoms, in a way, it's a mixed blessing because at least then maybe you might go get help earlier. But
Yeah.
some are completely shocked. You know, the number of women who can't conceive, having trouble to conceive. I don't know. Very often it's the man, but you know, once all the tests are done and it isn't the man,
good thing
then
in Pakistan, there is so much awareness about PCOS. And they're working on that from lifestyle management, from nutritional point of view. So they're fixing that.
what was the percentage in Pakistan? It
I
was
think it's 50%.
Yeah,
something.
more than
It's
It's
something
huge.
outrageous.
Over
So
very, very
if
huge.
they're fixing that, and these women are at risk of having a premature menopause too. So, or even if not premature, but then the early onset of menopause, like if average age is 50 or 49, they may have like 2 or 3 years earlier. So these women, whenever they come to my patients, that's what I do. I don't know how you do your practice. I tell them, you're on a biological clock. Your biological clock is little bit messed up.
Get your eggs freeze. Get your
Yeah.
eggs freeze.
If you can
That's
find the
an
right
option.
person,
Is that a good option
You
here?
can find.
I mean,
mean,
only if you can afford it.
Yeah, only if you can afford. That's very expensive.
It's like anywhere,
Yeah.
but is it
But the
crazy
awareness-
expensive here?
It is.
It is.
Should it not be?
But at
I mean,
least
this
just
should
telling
be
your
edited.
patients.
Should it not be only for
You
the
do
people
have
who can
options.
afford it?
Don't be silly.
You should not have a child if you cannot afford to educate them.
Yeah,
There's
there's
another reason
but
why
I
people
will
might
edit
not
it
have a
because
child, but,
this will get us a lot of hate.
But like just awareness, if you have some hormonal issues, some symptoms or the
mothers
periods
should-
abnormal,
yeah.
the mothers need to sit down with their daughters and tell them you're on biological clock. You can continue your education. You can continue your career and everything. Just make an informed decision, because here in this country, like, you know, even the age factor is a huge thing that adds to the, it's a social issue.
Not even in this country,
Everywhere,
women
everywhere.
are on biological clock. I mean, we can't
but
deny
like here,
that.
like biological clock from point of view, like if you're looking for a rishta, you're looking for you're looking for a marriageable age. In this country, is more like, it's like, oh yeah, she's 30 plus.
So one other thing to add also about the absolute contraindications is that if you are currently on a breast cancer treatment regimen, chemotherapy, radiation, you're currently on your cancer journey, much as that phrase pains me a little bit, but
Okay.
then it absolutely contraindicated.
Oh, you can't have it.
You cannot have it.
Okay.
A family history, anyone in your family, the number of patients who come to me and say, oh, my mother had, my sister had, therefore I can't, or I've been told I cannot because someone in the family has had a cancer, is not the case anymore. To Dr.
I mean,
Skandar's
I'm an
point
example.
about,
Yes.
it is not a contraindication.
I mean,
And can I add to that? Because I think what's really important is to know that there's a difference between systemic hormone therapy and local vaginal hormone therapy. And local vaginal hormone therapy is not contraindicated.
really?
Either in a family history of breast cancer or current treatment for breast cancer or a previous history of breast cancer. And genitourinary syndrome of menopause, so that is both the urinary symptoms, so things that more affect the bladder and the kidney, so feeling like I need to go to the toilet all the time, waking up more frequently at
And not
night
being
to
able
go
to
to
hold
the
it.
toilet, not
Exactly.
being able to hold
Urge
it.
incontinence.
That sort of feeling like I'm on the verge of getting a urinary tract infection all the time, or the vaginal symptoms in
Dryness.
terms of dryness and itchiness and discomfort. And I've had some patients who literally can't wear pants anymore because it is so sore when they just sit down. And obviously in terms of then how it affects their sex life, right?
Of course.
Just from the dryness perspective, the discomfort, all the rest of it. So those are the vaginal symptoms. And for that, a local vaginal estrogen or DHEA is absolutely life-changing.
So at 48 and onwards, the age, the American Urological Association has the new guidelines that after 48, 49, you can offer that to your patients. Earlier the better, because the reversal is difficult.
Yes.
So they should be on vaginal DHEA or vaginal estradiol.
What's the difference?
DHEA is another hormone,
Okay.
which is very important. So the vagina has different receptors. They have both the estrogen, the 2/3 and 1/3, and so DHEA actually can change into testosterone and estrogen according to the need.
Oh, wow.
So
That's a good hormone.
That's a good hormone.
Oh, yeah.
So, but again, if you don't have an access to the estradiol or so, then you have an access to the DHEA. But you're going to have an access to everything very soon, within a few
Yes.
weeks, inshallah. But having said that, as Mary said, even in active breast cancer, like when they have done all the treatment and everything and they're survivors, they come to you, after radiation or chemotherapy, their sexual life is, they're miserable.
Yeah,
There is
what
no
you call
quality.
it? Vaginal
atrophy, vaginal
Atrophy,
that
yeah,
dryness
Although
and
vaginal,
the
because it's
pain
both
during
sort of-
sex. This is the one thing, at least the doctor, without any fear, you don't have to get involved, the oncologists, because everybody's like the litigation and the lawsuit, and especially in Pakistan, they're saying, oh my God, the breast cancer and all that. Without any fear factor, at least start them on these local hormones.
Yes.
They stay local, they help you with you can make their sexual life better at least, if you can't offer them the hormones. One thing I would like to add with the fibroids, what I do in my practice is when somebody comes to me with the fibroids, after menopause, the fibroids start shrinking, the blood supply is compromised.
Exactly,
So
yeah.
when they start shrinking, I keep an eye on them. And as Dr. George said, like this is a relative contraindication. It's not a contraindication, but once they are stable and I know, then after the ultrasound, I do offer them and repeat the ultrasound again with the understanding the patient is aware, is a counseling that it may slightly grow, and if you're okay with that, we start with the hormones. After 6 months, I repeat the ultrasound, and again I repeat at 1 year. And if they stay stable for a couple of years, then I can go back to every 1 or 2 years and keep an eye on that. So that's a mutual, like a shared decision. Like the fibroids, you can use it and be happy with it.
So what's the proper protocol of starting BHRT?
So
proper.
the proper protocol is, well, not the answer that we will eventually get to, but I think it's education and awareness long before you might start having, long before you're 35. So menopause average age 45 to 55. Perimenopause, which is much more chaotic in some ways, and when the most dramatic
You start losing your hair and
Well, but that can last 7 to 10 years. So if you think at age 35, it is within normal bounds to start being perimenopausal. And one of the misconceptions is, then I can't get pregnant. You can get pregnant when you're perimenopausal.
Yeah, of course.
So that confuses a lot of people because they think, but wait, it's starting, so surely my fertility is going down. So
we are optimizing it, in fact.
So I compare sort of all our normal menstrual cycle years, our reproductive years, to super, like an ECG or EKG, I don't know what you call it here. Regular, then perimenopause is sometimes called the zone of chaos. Yeah. It is like this. And you can test your hormones 5 times in the same day and you will get wildly different, disparate results. Then menopause, as we go off the chart, it starts going. And, testosterone, I was saying, that's a steady decline for men and women from around your 30s, right? Then your estrogen and progesterone, they do the slightly falling off a cliff thing. So that's the first thing, right? If you're aware. So, our daughters are going to know what's coming, and that's the thing. It is not a little niche market. Menopause is not having a moment, as I've been hearing sometimes.
It is going to happen.
It enrages. If you're lucky enough to live that long, 100% of 51% of the population. That's really not your definition of a niche market. That's mass market. And gets into our definition of like the type of heart disease women have. I'm digressing now for a change. But it's called, when women have not the classic heart attack of the clutching left pain, the jaw pain, the neck, down the arm, it's called atypical. Because 51% is atypical, but it's because all the research up to now has been done on men.
Yes.
Until 1993, all large-scale NIH, National Institute of Health Studies.
We have one man in this show.
Exactly. Has been. So that has been the standard, and women have, as a consequence, been treated on dosing of drugs, on protocols, treatment, all as sort of smaller men.
Yes.
Or assume that we're kind of in the same boat. And it's not because men don't want to, have women survive. There's partly a good reason for it. It is also because are you familiar with the thalidomide scandal?
Yes.
I don't, please.
So thalidomide was caused by so there was a new, the name escapes me now, a new anti-sickness drug.
Okay.
Anti-nausea, anti-emetic during pregnancy, which was phenomenal and worked beautifully and was hailed, because that's a big problem in pregnancy. And then it turned out the babies were born, many of them, without arms or without legs.
Oh my God.
One of the greatest tragedies of medicine. I mean, it is a horrible, horrible, horrible story. So as a consequence of that, and rightly so, the entire medical establishment, or everyone, is very careful. So a lot of women of childbearing age have been completely left out of medical studies, partly to protect them, to protect the children, which is legitimate, but it extends to all women to a large extent, right?
Yeah.
And and the gold standard for medical research is you want just the thing that you are testing to be the only moving part. You want to keep everything else the same, because only then can you conclude, because you have this one or you have the placebo, for example, right?
Yeah.
Only then can you legitimately say this caused it. Otherwise, you have what's called confounding factors, any number of other things that could have played a role, you know? Yeah. And it becomes a correlation as opposed to a causal relationship, right? So
That protocol.
That protocol, exactly. So the protocol for starting, sorry. So starting BHRT. I think you started talking about it, right? You were saying, Dr. George was saying.
So I always start with a history first. Physical exam, basic blood work to make sure that there's no absolute contraindication, relative contraindication, like Dr. Mufti touched on. You should have your liver checked. You should have your renal function checked. You should have your CBC, basic blood work, and hormonal level. And to the point of optimization, we usually also check the thyroid function whenever we're starting people on hormone replacement therapy, because again, it's the idea of optimizing the whole environment rather than just looking at one specific issue.
And also some of the symptoms overlap with some of these. So we're trying to exclude other things that are easily treatable and fixed.
Exactly. If I can add to that from a functional perspective, is the reason for checking all of those things is not because we think that hormone therapy will do harm in any of those areas. So when you're saying, let's check the liver, let's check the kidneys, but right back to the beginning, that knowing that menopause is a time when we biologically age faster, we need to know, where are we now?
Yeah,
if we want
need
to ensure really good health span, where are we at the moment? What needs optimizing? And so all those things that we're checking is giving us a really good sense of physically and biologically, where am I now? And what do I need to do to optimize? And the other things for me are to check some of the core things like vitamin D and iron, and because, you know, ferritin, for example, is one of the most undervalued tests to do, right? And especially in your perimenopausal woman, where perimenopause, when you look at what's happening with the hormones, you know, estrogen is at times really high. As you know, we were saying, it's sort of swinging. So by definition, your estrogen is higher, and progesterone is diminishing because you're ovulating less, right? You're having more anovulatory cycles. And so that has an impact on the uterus, which means that often her periods may become a bit heavier. So she's bleeding more, so she's losing more iron. And that in itself causes symptoms. It can cause the brain fog, it can cause the fatigue, it can cause depression, and it'll make the periods heavier. So it becomes this vicious cycle. And just correcting that for many women is a life-changing thing. Just correcting her ferritin, and it's the simplest test to do.
I would like to add to this also, for what I have started recently doing. At 35, as you said, Mary, like, it's not to make a diagnosis, because you can make a diagnosis of perimenopause, just the history is enough. But it gives you a baseline.
Yes, exactly.
So baseline hormones.
Where were
at
we,
35,
where we are.
and now at 45, okay, let's just see where your estradiol levels are and where your testosterone levels are, because women sometimes in early 40s, because of the estrogen spikes and all that, the sex hormone binding globulins also gets altered, and some of the bioavailability, means like available testosterone, changes. So some of the women's, actually their free testosterone goes higher and they become more hypersexual than, as you said, like 40 naughty. 40 is naughty.
I need to experience that once in life.
And then they start having a little bit hair on the face, and you start plucking and all this, and that excessive testosterone can cause the hair fall. And just like that, the ferritin, which is the stored iron form, just looking at the hemoglobin is not enough, because, oh, my hemoglobin is 14, I'm good. The stored iron is important. If the ferritin levels are not 60 or 70, you can't sleep well.
Yes.
One of the things you need to add, because if your hair is falling, you need to make sure your vitamin B12, your folate, your zinc, your selenium, your copper, all that is very expensive. But you just sit down with a patient, and if they're rich enough, you just
their
do.
priorities are.
Or their priorities are at the right place.
I won't buy like a $2,000 bag. I'd rather have
which
my
you do,
BHRT.
but
No, not anymore. Not anymore.
So basically, you sit down with the patient, like, this is the minimum what you can do. If only 3 or 4 blood tests, then I'm okay with that. But if you want to do the whole general comprehensive workup, especially thyroid, because that symptoms overlap. The imaging is important as well, which is for prevention. You want to have a baseline ultrasound before you start the BHRT, because you want to look at the lining, and especially if they start bleeding later, you know like what was the initial lining. And then the mammogram or the ultrasound of the breast, depending how much they can afford, and the DEXA scan, which is the bone density scan. Again, it comes down to the budget, how much they can financially afford, and these are, in US it is all insurance covered, but here I have to be very careful what you're ordering, because once
you start with an annual exam, right? That's
yeah, but here in this country, women don't come for the annual exams.
Right. Well, that's another thing. Like, okay, we have to force this idea. The BHRT is a good window to make sure annual
that they get the
exam
annual
is done.
exams.
Like
In
a wellness
Pakistan,
check.
yeah,
Wellness
awareness.
check.
So how much testing? Once you got your baseline, you get on your treatment, then how many times you go back for testing?
Depends what you're on.
Everybody
right?
has their own protocol, so you start with your own, because the BHRT, there are no guidelines. It's the experience and the seasoned doctor. So what I do might be different. The standard of care is going to be same. There may be a little bit differences. What I
Do you see how much a certain patient requires?
Yeah, like you can
So
start
you
from,
have everybody has independent dosage.
yes,
Yes.
it's very customized. You can start from yours, and then we can tell our own protocols.
So I will tell you my approach to this, because I also, like Dr. Mufti, not only practice in the US, but I also practice overseas. So now we have a symptom checklist. So let's say if I have a patient on a budget, once I start BHRT, I bring them back in 1 month to go over the symptom checklist rather than doing blood work testing,
which is expensive.
Because it's expensive. But if the patient has improved and no side effect, I kind of understand that this is the right dosing for them, and I will do the testing usually twice a year just to make sure that we are on the right track and more for safety purposes. But it's not necessarily to keep testing all the time like it used to be, because like I said earlier, medicine is getting better, the preparation is getting better, understanding of the disease is getting better. So I don't have to keep checking and costing the patient all the time.
All right.
That's my approach.
Yours.
Yeah, it's a very similar approach. So I make sure that by the time I see a patient, I have a really full comprehensive history from them in terms of both family history and their own, in terms of factors that may be affecting their health in general. I do laboratory tests in terms of looking at all the systems that we've been mentioning, and specifically those that are going to influence cardiovascular disease, so inflammatory markers, etc. And then we have a discussion about HRT, and we start it. I do like to know that they have a strong relationship and they have done their annual checks with their gynae, and that there is, because I don't practice as a gynae, obviously, and they, I want to know that is up to date. And from a repeat perspective, I go very much by symptoms. So every time a patient sees me, they fill in a symptom questionnaire so that I can see where she's improving. Yes, we do practice precision hormone therapy, so I adjust each individual hormone based off what I'm seeing in her symptom cluster and improvement. And I do use blood levels in terms of estrogen, testosterone, etc. I don't use progesterone, but I use estrogen and testosterone in cases to help fulfill the picture. So I don't rely only on the level and alter levels or dosing based on the level. But I do use it if I'm thinking, is this woman even absorbing her hormones? Or, if there's a scenario where we're not sure on what's causing a symptom or not, then the blood work can be super useful. So I think, it's such an area of controversy, and there are so many people that go, you must never do hormones, and then on levels, and then the other ones where you go, you must always do levels, and in medicine there's never that case. And so I think the important thing with all of us is that we all have a different approach, but we get to the same end goal, because the patient and her well-being is my end goal. And so I will work with her and initially see her more frequently to get her to that end goal. And once she's doing well, I can see her less frequently. But when that is my goal, which is all of our goal, then we may have a slightly different approach, or maybe a test at this time or that time. And I think at the moment, one of the concerns for me is this narrative around there's a right way and a wrong way. You know, that you mustn't ever do this kind of thing because, or you must do this, or, you know, and that just confuses patients, because then they go and see a doctor, and this doctor seems to have a little bit of a different approach. The bottom line is ultimately that doctor must be there for your well-being. And they must listen to you, and they must hear your symptoms.
And give you time.
And you must feel like you've had the time to really truly express what it is that's bothering me. And you must be able to speak about things. You must be able to say, my weight really bothers me, without being told, don't worry about that. You know, like, if that's what bothers you, that's what bothers you. And if it's your skin that bothers you, exactly. And so we must work with you in terms of what's possible to optimize where and your health goals with all of the information on the table. What's good about that, what's not good about that, whatever. And that's the kind of relationship that you need to be having.
Especially
with
functional medicine doctor. Yeah.
Exactly.
So, Shivana.
What I do in my practice, because I practice in USA and here, so a little bit difference in both places. In USA, I do very comprehensive workup, because they come to OBGYN with I'm the primary care, so I have to work as a gatekeeper as well. So many of my patients don't go back to general practitioner and they say, you're the gynecologist, let's do the pap smear, do the mammograms, do the everything related to that, and the basic blood work. We talked about the basic blood work. I include my thyroid, ferritin, folate, and whatever they can afford, the general hemoglobin, A1C, and the fasting insulin also a part of that. And then the baseline hormone levels. The baseline hormone levels is not to treat the labs, to treat the symptoms, but also to monitor for the optimization. I do monitor the levels, because this way I can keep track when they come back to me with some side effects. Oh, I can't tolerate progesterone. I don't do the progesterone levels, but I do know, like, you know, testosterone, what levels I have to add, and what estradiol levels I have to go. And then the imaging, what I do. In Pakistan, I don't do much of this thing what I discussed. It's very expensive. So I do very limited, just the FSH, estradiol, and testosterone, free and total, and the thyroid, TSH. And if somebody is complaining of the hair fall, or like then just the nutritional deficiency, what is required, like a ferritin and the baseline. So I don't do much blood work, but I do tell them, if they at least, because there is not much prevention in this country, they go to the doctor only when there is somebody sick, pregnant, or dying. So I do tell them, at least get the mammogram or the baseline ultrasound, because you have never gotten it, or the DEXA scan. So according to the patient, I adjust, and also according to the country and how much their affordability is. So it's not about the labs, it's both. Labs are for monitoring, and symptoms are for the patient. So I can adjust their...
So the cream, estradiol derma cream you brought in Pakistan, it has the safest level that anybody can use, or again, you have to?
I do monitor.
Okay.
I do. So my protocol is usually the first 2 months when I start somebody, I do offer them the online. They don't have to pay, but they become like my sisters or my friends, and they have an access directly to me on my WhatsApp. And they keep talking to me even in the middle of night, like, okay, I have this, I forgot, I have brain fog. You know that I have brain fog. So how would I remember? What did you tell me? So first 2 months, they text me for every single thing possible. Like, even like, you know, oh, you told me like 14 days on or 14 days off, or like what? Or I am having little bit spotting, and I tell them explicitly when we start them, but then they forget, and they'll ask the same question over and over. So first 2 months, I give them free of charge, and after 4 to 6 months, I said, please come back for the official visit, which they don't, because they have an access to my WhatsApp. They keep continuing free on the WhatsApp, but they should come back after 4 months or 6 months to monitor the levels and to see where they stand, how the symptoms are.
Then you add and subtract whatever you feel.
So this is, yes, because I don't start with testosterone. If somebody comes to me, some people do.
Start with me.
Yeah. So some people come to me, and I always ask them, tell me the 3 symptoms which bothers you the most. Yes. If they come to me and they say, my biggest problem is that my husband is going to divorce me because I hate him, I don't want him to touch me, and I have zero sexual desire. then I don't wait because they're already miserable and that's the common complaint. They came to me for help. Then I do add on the first visit the testosterone after checking the labs.
No, I'm asking about your cream dosage.
Yeah.
Is it the safest you start with, or then you like, I don't know how many milligrams?
It's 1 milligram,
Yeah.
so per gram. So what I do is that's one pump. And when I check, because my estradiol level, as we were discussing before, everybody monitors their own levels. I don't want them to be 500 or 400, which is a normal young 20-year-old. I don't want to be fertile anymore. I'm not trying to make her pregnant or something. But like in the upper hundreds or 80s, according to this, plus the symptoms. So I monitor both. And if they're feeling great, I don't worry about
So
that.
a pump or 2 pumps or 3 pumps
According to
will
that,
add.
I go up.
All
I go
right,
up.
all
But
right.
let's say somebody comes to me and says, my hot flashes are still there, or I'm still feeling fatigued, or I'm still feeling. So then that's where the labs help me to monitor the levels. And as I was saying, testosterone, I make them estrogenized first. So that's the terminology we use.
Okay.
So once they have the estrogen and progesterone for 4 months, when they come back, I revisit the symptoms, sitting down with the patient, and I ask them what else you are feeling, if the fatigue is still there, the brain fog is still there, and their sexually desire is still not better. And I put them on testosterone. Sometimes, please, we have to be careful. We're not making them Superman. Some people think, oh, testosterone is going to make me like a Superman or make my muscles.
Why not?
Or
I
like,
wouldn't
yeah,
really want
or
to be
like,
Superman.
you know, or gonna get my beard out. No, you have to be on super high doses for that.
yeah.
So sometimes even when they have those complaints, you can give them a trial of 4 months or 3 months and then see how they do. Because don't forget, like fibromyalgia, when there is no
Exactly.
reason
No
for
reason
fatigue.
for anything.
And you can't find the reason.
Yeah.
The studies have shown just giving a low dose of testosterone on fibromyalgia
that.
patient and they
Wow.
feel good about it, why not? Why not? It's not gonna kill you. It's not. So you just go with the symptoms of the patient. So that's what I do in my practice.
Now it's your turn.
So I do a lot of the similar, I think maybe most similar to what Mary does and what you do in the, what Shivana does in the US as well. So there's the baseline, checking for, you want to make sure your patient also has like a blood pressure check because you don't want to treat unmanaged hypertension. Somebody on antihypertensive medication with a controlled blood pressure, no problem. You want to check their, well, I'm not going to repeat the whole list, but you know, the
After doing
HbA1c,
all
your
that.
fasting glucose, all these things. So in the UK currently, the guidelines say from age 65, you get a bone scan, a DEXA scan that,
Yes.
that tests the brittleness or the strength of your bones.
Thanks to her, I know everything.
Fantastic, fantastic.
Yeah.
It's too late at 65.
It is late,
Completely too
exactly.
late.
It is very late.
Then you already have a fracture.
Well, well, that's the other way people find out,
Fracture
right?
mostly.
Yeah, that's how I found out in my early 50s. I broke both my wrists from a fall that was kind of might have. Often we say like the way you realize there may be a problem is when somebody falls,
Exactly.
man or woman, but falls where other people wouldn't break a bone.
Yes.
It's you just fell from standing. You shouldn't break something. You might get bruised, you might get sore, but you shouldn't break something.
Yeah.
And so I had no idea. And then I looked at my mother, who's gone now. Turns out, looking at her medical records, she had osteopenia.
Oh.
Surprise. So, and I'm also as a very, tall, whatever, Scandinavian. I'm like the
Slender.
poster child
Yeah,
for
yeah,
typical osteoporosis risk factors, right? So a DEXA scan, early days, again, for that, like we said, for the baseline. And you might catch somebody who's borderline inching towards osteopenia or who is osteopenic, which is the stage before osteopenia, osteoporosis.
Porosis.
Yeah, there's normal, osteopenic, which is low, and then you've got osteoporosis, which is full-blown disease. Again, full-blown disease, but no symptoms until you break something. Right? So that is very useful because also it's not that it will direct, because it's a little bit like if you know you are on your way to brittle bone disease, you are more likely to be motivated, incentivized, like, oh, I don't want to be
Energy.
Yeah, but I don't want to be one of 2 women who is going to have an osteoporotic fracture before my time.
Yeah.
I don't want to end up in a wheelchair. I don't want to end up bedridden. About the quality of life we were saying, you know, your quality of life years. Don't want to be that. And also, of the 1 in 2 women who have an osteoporotic fracture, 30% are dead within 12 months.
Yeah.
Gone. Not because they died from their fracture, but from the follow-on. They never regain. 50% never go back to the home that they were living in. They end up in some kind of other assisted living, some other situation, because they never retain their independence.
Yes. We take it as the end.
Yes.
Yep.
Because
And
they're
for
gonna
good
be-
reason, though. It shouldn't be, but it is. And it's so prevented. It is so prevented.
Even
Preventable.
after you have it, you can make it better.
You can. We didn't used to think so. It used to be if you
Once it
start
happens,
treatment,
it happens.
it's going, no, but that your level of osteopenia, osteoporosis, you can stop it from progressing further, but you can't reverse it. But now we know you can. I'm living, breathing proof. I've reversed my osteopenia with hormones, and this is something that I'm sure we're going to get to, but we're talking about hormones. Hormones is amazing and can be and is life-changing, but it is one of what I call 5 pillars of what we all need to do. So movement,
Sleep.
exercise, sleep, stress, nutrition, and then 5th, not last, is hormones and or supplements and or whatever we call additional stuff,
I mean,
right?
with
So-
advent of functional medicine
Yeah.
like
Yes.
you two,
You know,
with
And it's the
functional doctor
the
and-
thing is, that's the whole problem. The traditional doctors are not open to functional medicine.
I mean, she's
the
going
first
through
thing
that,
when I
yeah.
went back, I incorporated functional medicine into my practice, because without learning functional medicine, you just cannot learn the hormonal
you
health.
refer
You
to
just
one.
cannot.
If you don't know,
just
you can
cannot.
refer to
No, but
one.
if you
You
want
should
to be
work
a
together.
BHRT
Yeah.
specialist, you have to learn functionality. You just cannot say like, I don't know. I mean, you have to have a basic knowledge of
Basic
functional
knowledge.
medicine. And if you get stuck somewhere, because holistic medicine, Ayurveda, all that, the adrenal health, the hormonal health is all interconnected. You cannot separate it.
So that's the perfect team. Dr. Sammiya, I would like you to also tell, being in Pakistan, where people actually are so apprehensive about everything.
Well, it's
How do you manage? What's your
with
protocol?
great difficulties. My protocol is, so I get a lot of filtering of the people who come to me, because they know that I'm not a conventional doctor. So a lot of people who come to me already come pre-filtered, in the sense that they are either very aware and they have been keeping up with things, or they have
They
been
watch
through.
our show. Oh, they watch our show.
Actually, they sometimes make the most difficult ones. So we'll talk about that at some point.
Yeah.
But some people who are very aware, the young people who come to me are the best patients that I've had so far, because they've done so much homework themselves and they're really willing to change. And I have a lot of young people. Men I find to be the most obstinate and the least careful about their health. They are just too busy.
Well, the whole world had been taking care of them in studies and everything. Yeah.
So, and they come, the women who come to me come mostly from the point of view, they've been through certain things which have not been treated by the conventional medicine. And then they struggle so much that they eventually end up with me. So my testing is a little more comprehensive. It's very similar to Mary's. I test for a lot more things than just the hormones. Of course, I do ask for the hormone panel as well, because without everything together, I won't be able to get a complete picture. And then the history part is really very important, because in Pakistan, there are a lot of tests that cannot be done. We don't have them available. So it's me being incisive about my questions, going into their childhoods and their traumas, and a lot comes out. And sometimes if they can afford it and they're willing, and if they want to move forwards, then I add tests later on. But testing, I like to keep scientific parameters, so I do think that it's important. As they improve, I check things. If they're not improving, then I check things. Symptoms are again more important to me than the testing. Sometimes the symptoms tell me a longer story and which are just corroborated with the tests later
Or they
on.
contradict the,
Yes.
you know, because so much of what
yeah.
you started talking about was, we talk about dosing, right? And
Yeah.
how many pumps,
Yeah.
or if you're wearing a patch, how many patches, what? But you can put, you know, I could have 6 patches all over, you could have 1, and we may have similar circulating levels because our skin, as this huge barrier, is there to protect us from all kinds of stuff. But it's
And the
also
weather.
and
And the weather.
yeah, the weather, the sun, everything, right? Exactly. So we were saying, one of us yesterday was talking about some patient who said, I'm not feeling anything, I'm not feeling better, and had a high dose of a cream. It was wintertime. When it was in South Africa,
blood
the
gets
winter,
constricted.
and so they get dressed quickly because they're cold. So
It
part of the
sort
of
it
keep yourself warm
it
with the
wipes
body
off in a,
temperature.
you know.
I have a patient who said that she's not getting any relief from the estradiol cream. Turns out that she was applying it after getting her oil massage done.
Right, yeah.
have a barrier
but,
on
you know,
it.
that's like
I mean,
that's like
common sense.
No,
it
but
kind of
it's-
is.
but
We
it's-
think, right?
We
For
think
the
it's
but
common
and then
sense,
you
yeah.
to your point about like how the example that who was that? It was somebody. Oh, he was actually on the airplane over. I was sitting next to a doctor for one of it, and he was talking about. We were talking about hormones actually, and then he, of course, that's all I seem to talk about these days with anyone. And my poor unsuspecting neighbor on my plane, right? No, he was a doctor, so at least he was
I
interested.
mean, that's me also being without a doctor. I start giving information.
Or
How much I know.
But he was saying he'd been at a respiratory, he'd done some respiratory research in asthma. And we were talking about techniques of application, and inhalers, you know, are notoriously difficult and very open to interpretation. And the number one reason asthma inhalers don't work is because they're taken incorrectly. And his example was, and I kid you not, he was in a group, sort of a therapy in the hospital session with a bunch of patients, and they're like, right, show me how you guys have been taking your asthma inhalers for decades, okay? And this one patient took it and goes, shh.
That's sorry. Like she wasn't inhaling, she was just putting on the
She
skin.
was spraying
So
it
just
on the
assume
outside.
It's called inhaler for a reason.
Well,
Yeah,
clearly
but-
that's open to interpretation.
No,
you know.
all right.
You're inhaling
What-
while it's on.
But you see, if
Huge
that,
assumptions over
that
there.
is
Like,
so
I will
important.
inhale it.
Forget about the patients, the doctors. If they have like tinnitus, like, you know, a ringing sensation, the dry mouth or the bleeding gums,
Yeah.
or even your lungs have estrogen receptors. So your asthma improves. So basically your pulmonary doctor, your GP, your family practice, and then as we talked about, like your brain has all these receptors, the not just the happy hormones what we talk about, but for the estradiol and progesterone and everything. So basically these doctors need to know, because they're not coming to us as an OBGYN or to you. Sometimes they're just going to the ENT or to the neurologist or to the
dentist.
psychiatrist.
Or to the dentist.
As
To
a
the
dentist told her.
Make the worst.
Yes.
They do this to the prescription that I've given a few people, which has BHRT and possible supplements, and like, you're too young, rubbish.
Yes.
Oh,
This
absolutely.
Yeah.
too
Threw it
young
away.
thing is also
Too
killing.
young.
Yes.
Yeah.
Yeah.
This is a killing factor too. What do you mean by
What
too
do you
young?
mean
If
too
somebody
young?
is having
Somebody is
experience,
too old, somebody
is too young,
they have
or
a
it's just
reason.
that you are a woman, you don't need it because it's natural.
Yeah.
And like, you know, there are only few mammals who go through the menopause, probably some killer whales or some turtles.
Yeah, exactly.
And
Good
just
company.
a few
Yeah.
chimpanzees maybe. So you just live without hormones the rest of your life. Going back to your DEXA, that's a very interesting thing. If you want to see as a biomarkers and then the DEXA scan, the medicine which you use for osteoporosis or osteopenia prevention, actually, they're not reversing. The estrogen is one of the things which reverses and remodels the bones because it helps
Along with the medicine.
along. So basically, that's the first line. You need to tell the patients when they're in menopause and they're trying to prevent, they're not only going to stop, but they also can reverse and remodel because they work on both cells, which is osteoclast and osteoblast, the cell which is breaking down and the cell which is building up hormones. So if you do the DEXA scan initially, and then you do it like after 3 or 4 years or maybe 5 years, patient can see the improvement. And when they see it, like, oh my God, I'm on hormones, like, it's a life-changing thing when you can see with your own eyes the results. So it's very important. And when somebody falls, we were talking about the fall, they lose their mass. And sarcopenia, which is the mass, like you're losing, they can never come back unless you start lifting the weights like Arnold Schwarzenegger. So sarcopenia is the number one factor. When you're immobile, you are not going to be yourself and you're losing all these muscles.
So
Muscles
one of the
have
5 pillars
mitochondria.
is strength training.
The exercise, when she movement.
Exercise, yeah. I think
weights.
that the weight training and exercise is also such an area of conflict, and women are sort of told you have to do it this way or you mustn't do it that way, and movement is the key. And I find with my patients, the first place I start is to say, what do you enjoy?
Yeah.
Because if she
Lying
has
in
to
my bed.
That's what I was going to say.
I love it.
Sit
on the couch and
what exercise, what movement do you enjoy? Right?
Blinking my eyes.
Do you
If she
hate the
says-
least,
Exactly.
right? Yeah.
If she says, I love walking with my friends, let's start there.
Yeah.
I just don't like my friends anymore because I'm in perimenopause. I just stopped seeing them because I'm angry all the time. I hate them.
Another joy, another rage walk.
They're the negative people out from my life. There's so many women do that, like in this age, without understanding it's not them, it's me.
Yes. So there have been 2 revolutions in health, right? One, talking about BHRT, like all of us.
Yeah.
And second is GLPs. Okay. Now, recently we heard so much against Ozempic use, and there have been so many scandals, there have been so many cases, and everybody who's using GLPs is being demonized and being told that, oh God, you're using that. You judge people.
Really?
But because there are reasons you can't lose weight now.
But people are judged for being overweight.
Yes, that too.
So you-
And helping it is
Like,
again
you can't win either.
another judgment. You're lazy, you didn't make
in
much
Urdu,
effort.
But in
What's
the
your
most common
excuse?
statement is Ozempic use kar rahi hogi, buddhi lag rahi. It like that means like
Like,
she's looking
oh,
so aged because she
she's-
lost so much weight. Probably she's not working out. She's just using Ozempic. Actually, you are fat, then you're body shamed. If you lose weight, you are shamed because you lost too much weight and you started looking older. So you can't please people.
So, Dr. Skandar, you in the beginning said it's all about inflammation. Everything starts from there. So, GLP has made it possible to not get there.
So I'll start with the same concept, like hormones has receptors all over our bodies. GLP-1 have receptors in all our bodies now. That's why you will see there's a research about GLP-1 and Alzheimer's. There's a GLP-1 eye drops nowadays for certain indication.
Eye drops?
Yes, there
Whoa.
is. Yes, and I think one of the things that we see nowadays is a lot of inflammation markers coming due to food and the way our food is being handled and processed. The revolution of GLP-1 comes from the idea of anti-inflammation. So again, there is, if the inflammation is a systemic disease that affects every tissue in our bodies, GLP-1 will be a medication to help mitigate the risk of inflammation and all over our bodies. Same like the hormones. I don't see that's a competition. I think that's complementary to the use of hormones, that we are using GLP-1 in everything. And I really mean it. We use GLP-1 in the OBGYN world for PCOS. We use it for infertility. We use it for dysfunctional uterine bleeding. We use it to decrease the risk of endometrial cancer. There's studies nowadays around decreasing the risk of endometrial cancer using GLP-1. I think it's a revolutionary drug that we're soon be exploring it in every single aspect of medicine. There is a use for pulmonary hypertension. There is a use for everything nowadays has to include GLP-1 because it's the anti-inflammatory.
And what about microdosing? Now that's a concept, like the studies are being done on that.
It's the same drug, just giving in a smaller doses for certain people who are not
using it for weight loss.
Correct.
Yeah.
Yes.
Okay.
And it makes sense because they're not obese. They're not using it to decrease their weight. They're using it for anti-inflammation.
All right.
I think he deserves a hug for this.
Yeah, seriously. So in your practice in functional medicine, I mean, a lot of people when come to you are actually suffering from inflammation and whatever the results they get into. So how much do you add this in your work?
So again, I think the whole approach with functional medicine is really individualized medicine and around precision care in terms of where this woman or man is at and where we're wanting to go to from a health perspective. And carrying excess weight, having excess inflammation is not something that we should ignore or dismiss, or we should be actively managing it like we do everything else, because carrying excess weight, specifically at the point where we have obesity, is a massive health risk.
Yes.
And so we should be actively managing it. And currently the best therapies that we have are the GLP-1 class of medicines, right? So I think it's important, again, GLP is a natural hormone we make in our bodies, right? So we all have GLP in our body. It is a hormone that is released from our stomach as we eat, and the stomach stretches and we will release it. Normally it degrades pretty quickly, but in women as we get older, and especially as we go through menopause, it reduces because it's also dependent on estrogen, and how it works at the receptor is dependent on estrogen. And so we know that in perimenopause, it's a profound time of weight shift.
Yes.
Most women will come in and go, I don't know, I never used to have a tummy and now I've got a tummy, and weight is shifting. And we know that the first thing that increases is visceral fat. So visceral fat is actually the fat that you can't see. It sits around the organs.
Yeah, the yellow one?
And yes, and it is the one that actually triggers inflammation and insulin resistance. And that we know is starting to happen way before the final menstrual period, right? Yep. Way before a woman is actually menopausal. We're talking years before. And so that just is exponentially increasing 8% a year, by the way. So a person in perimenopause who starts off already on the higher weight area with a visceral fat that's maybe normal, but on the higher end of normal, will have a visceral fat in an unhealthy area by the time she even reaches menopause.
Yeah.
So we've got to look at weight, and we've got to look at what's happening. And for sure, what we now know from the research is that it is the most effective treatment that we have from the perspective of weight loss, and especially targeting initially visceral fat.
Yes.
And because it targets visceral fat, we then see the reduction, profound reduction in CRP. And I often see a woman who comes to me and she's had high cholesterol, and the first thing that's happened is she's been put onto a statin.
Yeah.
But nobody's looked at her inflammatory markers or her hormone levels, or and actually in women, the inflammatory marker is more cardiovascularly a risk than her LDL level.
Yeah.
And so reducing inflammatory markers in her is more profound from a health impact perspective than anything else. So these are amazing tools that we now have. They're groundbreaking, and that's why they're being considered geroprotective agents, healthy aging agents now, because of all the physiological
benefits
impact that it has. And most notably in the brain. If you look at the changes in the brain, again, the changes in the brain are profound in perimenopause, right? So the brain, the first thing, as estrogen starts to have its fluctuation point in perimenopause, and over the course of time starts to decline even though fluctuating, the brain is losing its ability to use glucose as its primary fuel method.
Yeah.
So that's where the brain fog and the mood changes and all the rest of it come from, is that suddenly women are going, I just don't feel like myself. This weight gain, the visceral fat, the brain fog, and it's actually insulin resistance in a sense in the brain. And so the brain has to look for alternate fuel sources, and it wants to use ketones, but it does so by basically degrading itself, which is like not exactly what we want, So I really do think that as we go forward, and as you've so well put, that medicine is advancing all the time.
Yeah.
And this is a key agent that I think we'll start to see being used. And there's so many studies on GLP-1s way outside of diabetes and weight loss,
Yeah,
you know?
yeah.
And I think, you know, again, there is so much, I mean, it's the bias on it and the for and against is so
Yeah.
profound. And a lot of what gets spoken about on GLPs is either, honestly, in terms of what I've seen in my practice, is women who've used them incorrectly. We unfortunately see a lot of women who get a GLP through a Facebook group or whatever. And it's just increase dose, you know?
Yeah.
So if it's not working, increase it again. If it's not working, increase it again. But there's no supervision, there's no looking at her diet and her nutrition. And I've had women who come to me and go, oh, you know, I took Ozempic and I felt amazing. Never had an appetite, so I just didn't eat. That's not what you want.
Exactly.
We're meant to feel hungry. We're meant to eat. We're meant to have good nutrition. And
fuel
good nutrition
yourself.
is so important. So you need to eat good food. You need to get fiber into your diet. So you've got to eat the right amount of protein. You've got to eat the right amount of fiber. Your nutrition, the value of your nutrition is so important. And then obviously it's helping you to reduce calories and you will slowly lose weight. But when you just don't eat, that's when you're
Then
going to
you
see
lose
muscle
your
loss.
mass,
Because your body's going to eat itself, right? So you're going to lose muscle. So that balance, and using GLPs is not about just using them irresponsibly. You need to be monitoring your patient and you need to see what she is doing, and you need to almost earn the right to be using it from the perspective of you need to eat
a good
properly.
way to put it, yeah.
You know, so like anything else, we just want to monitor your progress, and you should be physiologically and in yourself getting better and better and better. But I see profound changes in my patients, and it changes self-confidence,
It's
and it
life-changing.
is life-changing.
It is, yeah.
For sure.
And also what you were saying about how, you know, we're shifting about this. So in a lot of circles, we're moving away from calling menopause management bikini medicine, you know, so between your legs and here, to calling it a neuroendocrine transition.
Yeah.
Because
Absolutely.
so much happens up here. Most
And
things.
here, your
It
second
does,
brain, your gut.
But as a consequence of your hypothalamus and your pituitary and your messaging and what gets produced here and then sends signals down here. So the brain part of this is, and I was thinking when you're talking about the midlife thing, we touched on osteoporosis, we touched on dementia, and now this weight gain thing, and when it starts, and you said so much earlier than when you start seeing symptoms, the buildup of the visceral fat. But it's the same thing with osteoporosis and dementia. We are now reclassifying them in our minds and in the science to diseases of midlife, not diseases of old age, diseases of midlife that manifest clinically with signs and symptoms in old age.
Yes.
But we're laying down the amyloid proteins, the tau, you know, the tangles, in midlife. Now, 40s and 50s, that's what's laying the groundwork. Or that's, you know, the osteoclasts are eating away at our bones disproportionately from our osteoblasts that you were talking about that are building it in our 40s and 50s. And then we break in our
if we
later
talk
life.
about the GLPs and we're afraid, especially like when we hear on the Facebook or on some other social media, the side effects and all that, number one, they're using without any supervision.
Yeah.
And number two, they just get hold of some not very authentic, especially in Pakistan.
Yeah.
They're just selling it like hotcakes and without any supervision.
Yeah.
And they're using it to lose, even you're 10 pounds, oh, I'm going to get married in 3 months. Or
Quick
I want to
fix.
lose. The quick fix, they're not doing any lifestyle changes, modification in the exercise or what you eat. So when they're going to stop it, of course, it's going to rebound and you're going to gain double the weight because you were not working on yourself of the healthy nutrition. You're just doing the quick fix. And then you do too rapidly, then you start looking, oh, that Ozempic face or Manjaro face or whatever, because you're losing all the fat. You're doing it the wrong way, the too fast. It doesn't have to be Ozempic or Manjaro. Even if you do any crash diet or bariatric surgery, when there is a very, very fast, you're going to look older because you're
Muscle
not doing the
mass.
exercise.
And your lean
now
muscle mass,
recently
exactly.
they have... they're doing some research in UK. Actually, this year they started because I don't know, like maybe out of 400, the 10 or 20, I don't count me on that, but there's some number, the deaths happened because of the Ozempic use. So they started working on it, not knowing what caused that and the blindness associated with it. So they are thinking that there might be some predisposition or some genetic component of that lot that's why the death happened. So they're working on it, and that started happening, I think they have started the research 2 or 3 months ago. So maybe we'll find very soon, but there's so much previous research on that they're pretty safe if used in the safer hands under the doctor's supervision. So there might be some genetic, like that we saw some kind of side effects.
All right. Sammiya, in Pakistan, you know, people are so judgmental, and especially, I think thin people are so jealous of this medicine because they start, oh my God, without doing anything, so they are the ones who are actually jealous of people using Ozempic and getting the credit.
Everybody's
But
looking
you yourself
pretty.
first used it on
Yes,
yourself,
yes,
changed your
yes.
life. I mean, the way she has changed her health, her looks and everything. First she did it on herself, and then you started telling
I
people.
did it on myself.
So you did not look like this before?
I did originally, and then when my menopause started,
So now we're jealous because she lost the weight.
Yeah.
Without doing
And
anything.
she is zero size and I'm not.
it's a 2.5-year-old journey, and it took consistency, disciplined eating, supplementation, and movement.
Yes.
Movement,
Exactly.
movement.
Yes.
There are people who come to me, they cannot walk by themselves, and they'll say things like, but I'm told I'll lose muscle mass. Well, do you have muscle?
What are you doing for it? Yeah.
Yes.
Yeah.
Do you move? Blinking the eyes is what they do.
Maybe rapidly.
And then they're concerned about losing muscle mass. Well, what have you done to build muscle to begin with? It's something that has to be done under supervision at the risk of repeating everything that has been said.
Yeah.
We're going to say all of this all over again.
Yeah.
I'm just soaking in information from people who are practicing so many different fields and yet are all on the same page, learning from each other, sharing this information. It is just amazing to see that there are clinicians who are all here for the sake of the patient. Nobody's sitting here telling each other, this is not the right way to do it, this is not the right way to do it, or I have a better way of doing it. No, it's all
why
bio-
you weren't telling me?
Yeah,
Why I have
exactly.
been practicing for last 30 years, so
Yes.
I'm like a professor.
Yeah, exactly. It's all
And
bio-individual.
the credit goes to you, Shivana. I mean, I can never ever thank you enough
No, thank
for
you so much.
bringing
Yes.
these amazing people, and we have
Oh my
learned
God.
so much from you guys that I'm in tears right now. I'm so emotional.
You know,
We've had so
because
much fun, too.
Yeah.
You know,
because
we-
you're the
lots of laughs.
Oprah Winfrey of Pakistan.
Exactly.
And that you come to so that comes to my mind, like, where should we go for the podcast? Educated, eloquent, who can get the message across to the right people and eventually to the masses. So you are doing the best in Pakistan.
Thank
like,
you,
know.
Shivana. Thank you, Sammiya. Thank you all. It was a pleasure. I swear we can talk for hours.
Yes.
Yeah, and we will after the camera is shut. But I mean, whoever is watching this show, I will try to translate it with subtitles in Urdu also. But please listen to this show. Do your research. Whatever changes you are making in your life with BHRT, functional medicine, don't do it on your own. There's a proper way. There are people who are gonna look after you, tell you what to do, and start taking agency over your bodies, especially for women, and all this will make your life better. Your quality of life will get better. Again, it's not about how long you breathe. It's all about how long you live a life and healthy life. And with that, goodbye, and I'll see you another time with a different topic. Khuda Hafiz.